Well, hello, everybody, and welcome to IRG's Health Matters podcast. This is our podcast. Obviously, it's called Health Matters, but the emphasis is Health Matters. Why do I hurt? On our podcast here at IRG, we talk to various medical providers. It could be a physician, it could be a medical community, it could be an association. And again, our goal is to educate you, our listeners. And again, thanks for listening on different medical practices and different medical activities. Our primary goal here is at the end of this podcast, we want you to go away and we want you to have learned something. I know personally, when I interview these wonderful guests I always learn something. I'm excited today because I'm ready to learn with our guest, Dr. Mark Kohn. Dr. Kohn is an orthopedic surgeon. He specializes in joint replacements, and he is with ProOrtho in Kirkland, Washington. Dr. Kohn, how are you?
Doing well. Thanks, Shannon. Appreciate you having me.
Yeah, welcome to the show. We're excited to talk to you today. Before we get into our topic, I always am interested to find out. I want to know about your journey, Dr. Kohn's journey. I looked at a little bio information. You know, undergrad, you did your undergrad at Cal Berkeley, and then you went through various training. And tell our listeners about your journey, how it got started. More importantly, like why medicine, why orthopedic surgeons, and then your training, your fellowship training. Pretty impressive stuff here on paper, Dr. Kohn. Tell our listeners what you're all about.
Oh, I appreciate that. Yeah. So, I grew up originally in Southern California, and my entry into medicine was through my mother. She worked at Kaiser, and when I was in high school, she encouraged me to do some, medical service rotations, try to see, what it's like in medicine. And I was able to do an emergency medicine kind of visit, kind of shadowing docs and kind of seeing how they take care of patients. And ever since that moment, my life changed. I just saw how much of an impact medicine can have on people's day-to-day lives. And so after that, I started my undergraduate career at Berkeley, as you mentioned, and then I moved over to the Midwest in St. Louis and went to med school at St. Louis University. And then eventually I made my way back to the West Coast at UW for residency in orthopedic surgery, and then finished up my training with a fellowship in lower extremity reconstruction or hip and knee replacement down in Scripps in San Diego.
Wow, that's quite a journey. For our listeners out there, this is pretty impressive pedigree. I mean, undergrad, UC Berkeley, medical school, St. Louis University. By the way, for our listeners out there, St. Louis is a very good program, has a very good physical therapy program in addition to medicine. Orthopedic residency, University of Washington, fellowship. Now, tell our listeners about a fellowship at Scripps, but I want you to tell our listeners what a fellowship means because it's very specific and specialized training.
Correct. Yeah. So, not all providers do a fellowship. A fellowship is kind of an optional training track that you can do, and it allows you to further subspecialize in a specific topic. And so within orthopedic surgery, there's a lot of different subspecialties, people who focus on surgery of the hand, of the spine, sports medicine, hip and knee replacement, like what I do, shoulder, pediatrics. And so with a fellowship, you can really dive deeper into that subspecialty and really increase your case volume during training so that when you get out into practice, you've seen almost everything.
Wow. Okay. For those listeners out there, I mean, I think you're being humble, Dr. Kohn. I mean, what I know about a fellowship is that it is very intensive, and you come out of that 1-year fellowship and you have spent that entire year doing very specific work in your area of expertise, which is lower extremity joint replacements, hips and knees. I mean, and that's pretty cool. We do have something in common here. I did my graduate school in Los Angeles, and then I did an internship when I was in physical therapy school at Scripps Sports Medicine right there in La Jolla.
Oh, wow.
So pretty cool part of the world. Very nice.
Yeah.
When you said you grew up in Southern California, where did you grow up at?
So Sherman Oaks, which is a suburb of LA. Yeah.
Yeah. I lived in Sherman Oaks. I went to grad school at Children's Hospital, Chapman University in Sherman Oaks. I lived right across the street from there. I want to say, this is going back, I'm an old guy here, but it was Notre Dame High School. I lived across the street, and Notre Dame High School used to come out and the band would practice at night. I'd be in that little apartment that I had across the street trying to study, and they'd be playing the Notre Dame fight song. I loved it though. It was small.
Oh yeah.
Small world.
I was right. right in that neighborhood. So
wow,
that's amazing.
Yeah, that's a big area. That's a big area. Well, you've got some great training, Dr. Kohn. So this is what I'm going to do is I think that this would be fun. You provided me with a bunch of questions, and thank you very much. And one of the things I like to do that we have never done, we want to talk about your interventions and what you do and how you do it. But after we talk about that, I do want to go through these questions and kind of go through the total joint hot seat questions. I think it would be fun. But I mean, before we get there, tell our listeners what you do on a daily basis and patients you see and kind of what a day in the life in the office and at work is for Dr. Kohn.
Sure. Yeah. So, we have our clinical practice, which is split up in basically office time where we see patients in the clinic, and then surgery time where we are operating. And then that also kind of goes along with when we're taking calls. So sometimes we're dealing with patients who come in on an emergent basis through the hospital. Other times we'll see patients on a more routine basis when they come into our clinic. And my focus is really everything hip and knee. So whether that's debilitating arthritis or other soft tissue injuries, fractures, infections, kind of the whole gambit.
Yeah, and I see here on the information you provided, and I think this is something we should talk about because I think there's some confusion sometimes in the community, and that is this robotic-assisted surgical help in total joints, hips, and knees. It sounds like and looks like from what I'm reading, you have got some very specific interest in robotic-assisted joint replacement. And I think you did something at St. Anne's Hospital. And so tell our listeners what that means, because I want our listeners to really understand the robot's not doing the surgery, so to speak.
Right, and that's a common misconception. It's really robotic assisted, and the assistance part of it is more of a planning part. So, for example, when we do a knee replacement, when we do it with robotic assistance, typically we'll get some imaging before the surgery that will allow us to make a 3D model of the joint. And then with that model, we'll be able to actually carefully size which implants will fit that person's anatomy the best. And then furthermore, during the surgery itself, we'll actually use that information to help balance the joint when we're replacing the joint. And so throughout the surgery, I'm doing all of the surgery. I'm just using the robot to provide additional information for me to make decisions during the surgery.
Wow. For you listeners out there, you are listening to IRG's Health Matters podcast. Why Do I Hurt? We are having good fortune today to be talking to orthopedic surgeon Dr. Mark Kohn from ProOrtho down there in Kirkland, Washington. And today we're talking about total joint replacements of the lower extremities, hips and knees. We just got done talking about the robotic-assisted surgery, and I want you all to understand how important this is. I mean, Dr. Kohn, from the robotic assistance, essentially what it does from a computer standpoint, the layout, it gives you kind of a topography of the joint. It helps you look at the size of the replacement, how you should insert the replacement, degrees, angles. I mean, is that kind of what's going on there?
Absolutely, yeah. It's really almost like a navigation during the surgery, where we would typically have to use other clinical landmarks and maybe X-ray to help our guidance. With the robot, we could actually see a 3D model of what we're doing in real time.
Wow.
And so that really helps with, balancing the mechanics of the joint and then making sure that all of the bony cuts that we do to perform the surgery are very, very precise and accurate, and that there's very little tolerance or, cutting off of what the plan should be.
Wow. It's amazing. Like I told you listeners, I mean, this is what I enjoy about this podcast is I too learn something every day, and I hope you are too. Just to take you back, I don't know how old you are, Dr. Kohn, but when I was a kid, and that goes back a little while ago, every once in a while in the afternoon, you come home from school, you'd watch a program called Star Trek. I don't know if you've ever seen it or not. You probably heard about it. Yep. But I mean, I remember as a kid, I think on the ship, the Enterprise with the ship, the doctor, his name was Bones. And I think if I remember, and if you got sent to sick bay back in those days, Bones would scan you with the device and it would beep and buzz and stuff like that and would tell you what you had. And as I'm listening to you, I mean, it brings me the technology, the advancements. I mean, when I started this physical therapy business 36 years ago, I mean, total joints were only being done if you're 65 or older, and they were very, I don't know, they were early. They were early,
Right.
kind of. I mean, and the technology. I mean, it's not just the robotic advancements and the surgical technique. I talk about the implants, how they've changed from basic alloy metal. Now they're using ceramics, and the longevity, how long they last. And people often say, "Can I go through the airport? Am I going to get stopped at the airport?" You hear that a lot. So tell us about the implant.
Yeah, we've had a huge change actually over the last 30 years with the materials that we use with hip and knee replacement. It used to be in the early days that we were really concerned about the implant wearing out, particularly the plastic bearing surface that goes between the metal pieces. That used to be the point of failure, where it would cause a lot of debris that would wear out, and then that debris would cause a very bad inflammatory reaction. But now with new modern fabrication and manufacturing techniques, that plastic lasts way longer than it used to. And so, when we talk about the longevity of an implant, most people kind of cite anywhere from 15 to 25 years. And, that's with kind of previous generation of technology. So you can imagine now with this new generation of technology, we're waiting to see how long it lasts, because we have to wait another 40, 30 years to see how long it lasts. But the results are promising.
Yeah, it's really amazing. Like I said, the technology advancements and just minimally invasive surgery. And by the way, people, they're doing these surgeries in today's world. A lot of these surgeries are being done what they call ambulatory surgery centers. That means you roll in the morning, 8 o'clock, check in, and you're home in your own house, usually that afternoon. I mean, there's a lot of people that can have these done as ambulatory surgery goes. Why don't you talk about that, kind of the ease for the patient, the patient's family, and how that has changed kind of the world for you?
Sure. Yeah. So historically, when you used to have a knee replacement or a hip replacement, you would get admitted to the hospital the night before, and then you'd stay in the hospital, you'd have your surgery, and then you could be in the hospital for a week or longer before you'd be able to go home.
Yeah.
And, at first glance, you might think that makes sense, but in reality, the longer you're in the hospital, the more likely you are to have a complication.
Yes.
And some of the more common complications include infections, getting bed sores, getting things like pneumonia, and confusion. And so we've found that the more we can get people up and active and back to their, home environment, the faster they're able to recover, the less likely they're going to have a complication in most cases. But, it's not a one-size-fits-all situation. We always take into account the patient's age,
right,
their comorbidities, do they have help at home? Do they have the support they need? And so if it's not appropriate to do the surgery in an outpatient setting, then we definitely don't do it in an outpatient setting. But we just have this idea where we want to, really minimize the amount of time that you're in an institutional setting where you can have these complications just by being in that setting, when you could recover faster at home in most cases.
Yeah. It's I think patients, if they can, I think patients would prefer to be at home in their own bed, in their own house. And hospitals are great, but I think you get better sleep at home. That's my opinion. Just one guy's opinion here. Don't attack me here, people. But,
absolutely.
Yeah. Here at IRG, one of the things we noticed and one of the things we started, which we're always trying to collaborate with folks like you, Dr. Kohn, and also obviously we're about the patient, the patient's experience. We started a concierge service. So what we're doing is we are really helping the physician in the ambulatory surgery center to really educate and basically do the prehab education, follow the patient at the surgery center at home, and create some continuity care. And that's really great for the patient, because what it's all about, you don't want the patient going home and going, is my scar is incision supposed to be red, and what's going on here? So we're building programs to collaborate and obviously help the patient. So good stuff there on the technique.
Absolutely.
Yeah.
And you guys are basically our eyes and ears.
Yeah.
We set you up, the patients up with home physical therapy in most cases, and so the therapists are able to work with the patients directly in their home. And, if they see something that's concerning to them, then they could easily relay that to us. And then we can, can take quick action. So it's a great team-based model.
It's amazing when a therapist goes in the home, and sees some of the things that are going to potentially create some kind of a hazard, a fall. And you mentioned about hospital and then, being readmitted to the hospitals post-operatively, particularly with total joints. A lot of times it's an infection, it is a fall, or is it a hardware fail or something happens? But a lot of times it's a fall, and we want to be there to help out. You're listening to Dr. Mark Kohn. He is an orthopedic surgeon with ProOrtho in Kirkland. He is a fellowship-trained total joint specialist. That means he takes care of everything below the hip, knees, and other assorted activities down there, injuries, etc. Dr. Kohn, are you up for a game here? Are you ready to play along?
Let's do it.
Okay, this is our first time we've done this. This is going to be the IRG Health Matters hot seat, okay? And I'm going to go through some questions here, and we'll give you 30 seconds or so to answer them, and we'll just see if we can't do some speed knowledge. I've always liked a little bit of speed knowledge. First one up, hear it out of the chute. When is it time for a joint replacement?
So we always start off with non-operative treatment. We want to make sure that you've tried things like physical therapy, maybe anti-inflammatory medications, sometimes an injection, modifying your activities. And if you do those things, and despite that, you still have constant daily pain that's significantly affecting your quality of life, then it's maybe time to consider a surgical intervention.
You're good at this. You've probably addressed this kind of stuff in front of chief residents and attendings, haven't you? Yeah, it's pretty good. That's pretty good. Am I too young?
It's a conversation I have every day with patients.
Yeah,
so.
That's true. That's true. Good stuff. Here you go. Am I too young or too old for a joint replacement?
So, commonly what I tell patients is that age is really just a number. It's, there's a big difference between your chronological age, the age that's on your driver's license, and your physiological age, right? So how well are you taking care of your body? What comorbidities do you have? And so we really don't go by just the actual number. We take, the whole patient into consideration.
Awesome job. How long will this implant last?
So we kind of touched on this a little bit earlier, but, with new technology and the materials that we use for joint replacement, we typically expect that these implants will last 20 years or longer.
What can I do as a patient? This is a great question. Patients, if your listeners out there, if you're potentially going to be a patient, this is one you have to listen up to. What can I do to improve my outcome as a patient?
So there's some things that we can change and some things that we can't change about our health condition. So we really focus on what's modifiable. What can I do to make a difference? And so the simple things are smoking. If you can quit smoking and using any sort of tobacco products, that'll not only help you with your overall cardiovascular health, but it'll help you with your bony health. And it actually helps to minimize the risk of an infection from a hip replacement or a knee replacement, which can be devastating for a patient. Things like controlling your diabetes can be helpful, your nutrition, and sometimes doing some sort of rehabilitation in a preoperative sense, like a prehab, can also sometimes help you.
Absolutely. Good stuff. You're talking my language there. We say as physical therapists, we say prehab is the new rehab, okay? So here we go. Do I need medical clearance?
Yeah, well, really we focus on, the big ticket items, any big heart or lung issues. And so, if you've established care with a cardiologist, we'll want to make sure that the cardiologist is on board before you undergo this surgery. If you see a pulmonologist or if you have any other breathing issues, we'll also want those specialists to be on board as well. And then we'll also have some special consideration for different medications like blood thinners or any of the new GLP-1 medications or immunosuppressants. Those medications can have an effect on your surgery. So we just have to modify when you take those medications in order to avoid a bad outcome.
Okay. Here's a question. I hear this a lot when talking to patients and they're getting ready for surgery. How painful is this surgery?
Well, we do everything we can to make sure that your pain's under control, and we try to do it in a way that minimizes the use of narcotics. And so we call this multimodal pain management. And so that usually happens as a coordination with anesthesia right before your surgery. Oftentimes we recommend a nerve block that doesn't have any sort of narcotic medication, but it can help dull the nerves so that after the surgery, the pain is not as severe. In addition to that, we really focus on those non-narcotic medications. And so we'll try to have you be on a scheduled non-narcotic medication throughout the day, and then only use that narcotic medication very sparingly as needed for breakthrough pain.
Yeah.
And so usually that combination of the nerve blocks, any blocks that I do during the surgery itself, using that scheduled non-narcotic medication pathway, and then having that small amount of narcotics just for breakthrough pain, usually patients do very well with that.
Wow. For our listeners out there, I will tell you from my experience, 99.9% of patients that I deal with that decide to have a joint replaced, hip and or knee, always come back and they always say, man, I wish I would have done this 3 years ago. It's a common theme. If you're living in that pain, that arthritis pain, that dysfunctional pain, you're not moving around. I mean, it is worth it. And they have come a long way with pain control. Speaking of the surgery, how long does it take? How long is that surgery going to take you?
So in most cases, the surgery will take somewhere around 2 hours. But from the family's standpoint, or for other people who are waiting for you after the surgery, it could seem more like 4 or 5 hours, just because there's a lot of prep work in terms of getting you set up for surgery, making sure we go through all your medications, making sure that you're appropriately ready for anesthesia, and then getting you into the operating room, getting you positioned, getting you asleep, and then sterilizing everything, and then starting the procedure, then finishing the procedure, then waking you back up, then transferring you back to the table, back to the PACU. So all that stuff adds time to the whole process, but the actual time of surgery is about 2 hours.
Let me rephrase this. Now I'm struggling. When will I be able to walk, and what should recovery feel like?
Well, we want you to walk right away in most cases. And so that means sometimes in the PACU, but other times that means, if you stay in the hospital, that could be once you go to the hospital room, or if you go home the same day, you're walking to the car and you're walking around your house the same day. So really it depends on, your strength, your abilities, your pain control, but our goal is to get you up and moving as soon as possible.
That was my job when I first came out of school, physical therapy school. My first job was at Swedish Hospital. That's what I did.
Absolutely.
I went in, I'd walk into the patient's room the next morning after surgery. Hey, we're going to get you out of bed. Here we go. It was a lot of fun. Hey, what about driving and returning to work? Those kind of activities. I mean, driving is so important for so many people. What's your rule on driving?
So there's a few kind of stoplights, so to speak, for driving. You have to make sure that you're off of all of the narcotic pain medication. So we want to make sure that you're not taking things like oxycodone, tramadol, Norco, Vicodin. All those things you don't want to be driving. Obviously, that's a DUI if you do drive on those medications. So you have to be off of the narcotics. And then we also have to make sure that we're considering what side the surgery is on. So if it's on your right side, that's, of course, the leg that you use to hit the brakes or really control the vehicle. So if you have surgery on the right side, we're going to be a little bit more cautious. But generally, if you're off of narcotics and you feel like you have the strength to slam on the brakes if you need to, then we recommend that you drive with someone in the car first with you, kind of like you're learning to drive all over again. You start off in the parking lot. Then you work your way up to the side streets, then the boulevards, then the highway. What you don't want to do is go straight on the highway by yourself for the first time when you first consider getting back into the car. And so most people, for them, that takes about 3 or 4 weeks or so. But of course, there's always a little bit of wiggle room in either direction, depending on each patient's situation.
Yeah, like I mentioned earlier, I talked about collaboration with physical therapy and the physicians. This is where the physical therapist can really be instrumental, helping the patient and guide the patient in return to functional activities with communication with the doctor and the doctor's protocol. So that's why it's a great team approach, in my opinion. Here's a question. I've actually heard this from a patient before. After a knee replacement, they must be Catholic here. Just kidding. Can I kneel? Can I kneel?
Yeah, you're absolutely right. A lot of people who are using the pews, they ask me about that. And so the answer is yes. Of course, you can kneel. It's not something that's going to damage the implant, but it may be a bit uncomfortable at first. over time, that discomfort should drastically improve. But we often recommend that people who have to kneel for a living, they use things like knee pads, or maybe putting a pillow down before you kneel on something, or using a low stool.
Yeah.
So the short answer is yes, but it may just take a little bit of time.
The hot seat with Dr. Kohn. Last question. Here we go. We're going to wrap this up on the hot seat, but we're going to finish up with the most important question. And, a couple of years ago, I'm not kidding, I was on a chairlift at a ski resort, riding up the chairlift. The gentleman next to me, we were doing introductions, and he said, "I'm really excited. I'm out skiing again." I said, "What do you mean?" He said, 4 months ago, I had a hip replacement. I'm like, "Good for you, buddy. Good for you. That's awesome." Here's the question. Can I return to activity, i.e. sports, skiing, walking? What does that look like?
Absolutely. So when we talk about sports and activity, we really like to break it up into two big buckets. We call it either high impact or low impact. And so things that are high impact are things like running or jumping, anything where both legs are off the ground at any one given time. And you can imagine that if you're running or jumping, that's going to be putting a lot of force through your joints. And so that force is going to be transmitted to the implant. And so depending on the intensity of those sports and your abilities, we ideally would have you avoid high impact activities. Now, at the same time, I tell patients, if you're an expert skier and then you get a hip replacement, you probably can go back to skiing. But if you've never skied before, learning to ski after you get a hip replacement is probably not the best idea.
Yeah. Good point. But this guy was really, my point is, it was a wonderful chair ride because I could see the joy and I could see the enthusiasm in this gentleman. He was obviously a lifelong skier, probably at one point in time had significant hip pain, probably struggled to make the decision to have his hip replaced, had his hip replaced, was back skiing on the mountain. Obviously he's not doing bumps and moguls. We're not going off cliffs and things like that, but he was so happy to be back what he loved to do. And I think I watched him ski away, and it was a really cool moment for me because he just went down the mountain, he was carving, and he had beautiful form. And I'm like, good for him. That's great. And these,
absolutely.
Yeah. And this is here's the deal, Dr. Kohn. I have just met you. We have just talked for about 28 minutes here, just over the phone. I want to say something. I can tell how passionate you are and how much you care and how much you love what you do. And I want to give you big ups, big props, even though you're a husky. That's okay. And I'm just kidding you. I'm a kook. But I can tell you care for your patients. And I guess I want all our listeners to know that is what healthcare is all about. That's what we're all about, changing people's lives and helping people that maybe lost their ability and maybe they're in significant pain, and just doing a joint replacement and helping a grandfather return to walking with their grandkids. As a therapist, I love to do that, and so do you. So as we wrap up, any last words of wisdom from Dr. Kohn? They're at ProOrtho in Kirkland, Washington.
Yeah, thanks for having me, Shannon. I really appreciate it. I think that overall, the take home is that, the best outcomes happen for us, at least, is when the surgery, the rehab, and patient's expectations all align. So
yes,
it's really all about patient education, working with your therapy team, working with your surgeon to have the best outcome. And so it's really important to really focus on that team-based approach. And I think that gives patients the best outcomes.
Exactly. If the patient knows what to expect and what post-operatively is going to look like preoperatively, and they're educated in communication, the outcomes are so much better, and so are the results. It's all about collaborating, all about communicating, and you and I are on the same team. Hey, listen, guys out there listening, this was and will be in the future IRG's Health Matters. Why Do I Hurt? This is a podcast about education. We just shared some great time with Dr. Mark Kohn, orthopedic surgeon, a fellowship-trained total joint replacement surgeon there at ProOrtho in Kirkland. And if you want more information and follow up with Dr. Kohn, he is at ProOrtho.com. But Dr. Kohn, I know you have a website that you personally check all the time. What is that for our listeners?
Absolutely, yeah. So you can also reach me at mdkohn.com.
That is, say that again, mdkohn.com. Say it again.
That's right, mdkohn.com.
Dr. Kohn, thank you very much. Appreciate it.
Thank you. Appreciate it, Shannon.